Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 60th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Minimally Invasive Spine Surgery, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can do it once it is posted on the IBJI and NSYMCA websites. People often gasp when they hear about someone having spine surgery, but a lot has changed over the past few decades and even years when it comes to surgery of the spine. Tonight, IBJI's AJ Minkara, MD, will help us discover the benefits of minimally invasive spine surgery. Dr. Minkara will discuss outpatient surgery options, as well as preparation tips and recovery insights before we open the floor to the question and answer session on this innovative approach to spine care. As you listen, take notes and compose your questions to be ready for the Q&A portion. Dr. AJ Minkara is a Harvard and Cleveland Clinic trained orthopedic spine surgeon who completed both surgical and research fellowships, including research at Columbia University, focused on adult and pediatric spine conditions. Recognized for his excellence, he graduated summa cum laude and was inducted into the Gold Humanism Honor Society for Excellence in Compassionate Patient Care, and was awarded multiple grants and honors. His work has been referenced in more than 600 publications, and he authored the Adult Spinal Deformity Chapter, Chapter 17, of the American Academy of Orthopedic Surgeons textbook. Dr. Minkara treats patients in need of all aspects of cervical, thoracic, and lumbar spine surgery. His specialty areas include adult and pediatric cervical, thoracic, and lumbar disorders, disc herniation, cervical disc replacements, spondylolisthesis, degenerative conditions of the cervical, thoracic, and lumbar spine, adolescent idiopathic scoliosis, computer-navigated surgery, spinal stenosis, spinal fractures, spinal instability, disc degeneration, revision and complex spine surgery, and of course, minimally invasive spine surgery. Dr. Minkara's expertise in minimally invasive spine surgery provides his patients with options for faster recovery time, less discomfort, and quicker return to their normal life and activities. He and his team use a multidisciplinary approach to tailor treatment for each patient based on their particular goals. Dr. Minkara says, "I believe in doing what's right for the patient. The patient's needs always come first. Doing what's right includes taking the time to listen to their story and what brought them in, understanding their goals of care, offering conservative treatment options, and using proven techniques and technology to deliver the best possible care." His patients agree. Every review I found gave Dr. Minkara 5 stars, and patients said things like this: "Chose him to do my surgery after getting a second opinion. Glad I did. My leg pain is gone. Great surgeon. He even called me at home after surgery to check up on me." Patient number 2 said, "Phenomenal neurosurgeon. Thank you, doc. He took care of my revision after several surgeons turned me down. I have Medicare and it didn't matter to him. I recommend him. Amazing surgeon." And patient number 3 said, "He's the best. 4 exclamation points. I was living with lower back pain and leg pain for 8 years. I saw other surgeons after the neurology surgeon I had before retired, and no one really helped me like he did. All caps, pain is 99% gone after surgery. Thank you." I could go on, but you get the point. Dr. Minkara believes in providing the best possible care, and I know that tonight you're going to learn a lot because he cares. During Dr. Minkara's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the questions section on your screen, and I will receive them and relay them to Dr. Minkara immediately following his presentation. I do ask that you keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Minkara via one of the options that will be listed on the slide shown during the Q&A portion of the program at the end of his presentation. One last thing before I turn the evening over to Dr. Minkara. Please mark your calendar for our next IBJI and YMCA Education Series program on Tuesday, March 18th at 7 p.m. Dr. Leanne Tu will discuss comprehensive management of carpal tunnel syndrome. Thank you again for joining us tonight, and thank you, Dr. A.J. Minkara, for your time and effort in putting together this program to teach us about minimally invasive spine surgery. Dr. Minkara, please take it from here.
Thank you, Karen. I'm going to share my screen. Perfect. Well, hello, everyone. I'm AJ Minkara. I really appreciate the introduction, Karen.
Okay.
So today I'll be talking about common spine conditions and minimally invasive spine surgery. I think that a little background on some of the most common conditions that patients can experience when it comes to the spine is very important. I found that a lot of patients tend to think that certain spine conditions that are not normal are actually a normal part of aging, and that's not the case. So a lot of times people are living with neck pain or back pain or pain radiating down their arms or their legs, or issues with walking or needing a walker, and they think that that's just how it is when people age and get older, but that's not necessarily the case. So the more you know about the spine and the more you understand what conditions cause what and what the symptoms are, you can start to understand that your quality of life can get better if you seek the appropriate care. So Karen already went through the background here. So I originally did my residency training at the Cleveland Clinic in Cleveland, Ohio. I also did a surgical spine research fellowship at Columbia University, and then I did my spine fellowship followed at Harvard. I'm currently with Illinois Bone and Joint, and I practice out of Barrington. I have clinics in Barrington on Tuesday and Wednesday, and McHenry Clinic on Friday. So this is just a quick outline of the talk so we can understand what we're going to be looking through today. A big portion of this talk is just going over some of the common spine conditions, and once we understand the diseases or the issues that can happen in the neck or the cervical spine, then we'll transition to the lower back or the lumbar spine, and then we can talk about minimally invasive surgical options. These minimally invasive options have good advantages when it comes to recovery after surgery, and we'll go after those, and I'll also show some examples of how the incisions look and why we have the opportunity to do minimally invasive surgery for certain patients. And so to start off here, we'll start by talking about issues that happen in the neck. And so the neck commonly gets referred to as the cervical spine, which is the upper part of the spine. Three main conditions that I routinely see. The first one is cervical myelopathy, which is essentially pressure on the spine that causes problems with walking. The second one we'll talk about is cervical radiculopathy, and that's essentially a pinched nerve, which causes pain going down the arms. And then the third condition will be neck arthritis. After that, we'll talk about the lower back. Just like you can have pressure on the spine and the neck causing issues with walking, you can also have pressure on the spine and the lower back as a result of arthritis or disc herniations. And the pressure on the spine and the lower back can also cause issues with walking, needing a walker, having issues with walking longer distances, and so on. Another common issue is lumbar radiculopathy, or a pinched nerve in the lower back. And that can have a multitude of causes, including a disc herniation, which is something quite common. That happens in young patients, it happens in athletes, it happens in older patients, so I see that across the spectrum of patient ages. And then after that, we'll talk about arthritis of the lower back. After we get that overview of the neck and the lower back, which are also referred to as the cervical and the lumbar spine, we'll talk about what these minimally invasive spine surgeries are. I commonly have patients come in and ask me, I looked up online and I saw this surgery called a tubular discectomy or a minimally invasive fusion. And so by understanding what the problem is in the spine, it makes more sense why these surgeries are now offered to patients. So let's start off with the neck. So the first condition we're going to talk about is called cervical myelopathy. And basically what it is it's a condition that happens in the spine where you have a lot of pressure on the spine after it leaves the, when you look at this MRI here, the brain is up top here. This is the bottom, this is the front, and this is the back. And this area coming down here is the spinal cord. These squares that you see here, these are the cervical vertebra or the bones in your neck. And then these in the back are the little bumps you can feel if you press on the back of your neck. And so this coming down here, this is the brainstem up here. If this coming down here is the cervical spine. And commonly over age, you can start developing arthritis in your neck. You can also have disc herniations. And this condition can be caused by a multitude of things, but the end pathway is all the same. You end up having pressure on the spinal cord up here in the neck. And as a result, you start having multiple symptoms. The most common thing we see is issues with balance and coordination. Over time, patients start having problems walking. They can't walk like they used to. They have issues with coordinating themselves. They feel like they're off kilter. That's kind of one common word that people use. You also have issues with hand dexterity. Your hands start to feel clumsy. You start dropping objects. A lot of times people will say, I can't really turn a doorknob like I used to, or if I'm holding a cup of water or a cup of milk, I'll drop it every now and then without intending to. And also feeling like you're off balance when you're walking. And so the problem here is a lot of people think, you know, I'm just getting old and I need to use a walker now, or I can't feel my balance. That's all abnormal. In many patients, if you have this pressure on your spine, that needs to be addressed. And so with this condition, if you take the pressure off the spine, you can relieve that compression. And as a result, you can stop that deterioration from occurring. And a common word you may hear your spine surgeon say, or if you go see an orthopedic spine surgeon or a neurosurgeon, they'll say that cervical myelopathy happens in a stepwise progression. What that means is you get worse for a while and it stays the same way. And after a while you drop and your function gets worse where you can't walk like you used to, or you go from a cane to a walker and so on. It stays for a while, then it drops again, and your function just deteriorates in a stepwise fashion. So that's what cervical myelopathy is. And if you know someone who, you know, used to be able to walk independently and over several years they suddenly go to using a cane or then a walker, they feel off balance, their hand coordination is not the same. A lot of times if they have arthritis in their neck, they can have the cervical myelopathy, which could potentially be addressed. So we kind of talked about the symptoms of cervical myelopathy. A lot of patients walk in with this walker. This picture unfortunately is missing one of the more common things that most patients do. They put little golf balls here on the bottom to let it glide. But you can have neck pain and stiffness. You can have tingling in your hands, clumsiness, instability when you walk, issues with going up and down stairs. And then in a very late stage, you could start having problems with, you know, being able to, you know, pee or, you know, other changes that are abnormal. And so this is a kind of a little picture or a caricature of what happens in cervical myelopathy. And you can see here this disc herniation along with a little bit of arthritis causes pressure on the spine. And the condition basically requires surgery, but you would have to make sure that you're a candidate for surgery if so, but this is something that can certainly be addressed. Moving on to another very common condition when it comes to your neck, this is called cervical radiculopathy. And basically, this is just a fancy word for a pinched nerve in your neck. And so what are the symptoms of cervical radiculopathy, or what do you feel when you have a pinched nerve? A lot of times you can have arm pain or numbness in your arm that goes down to your fingers. And this depiction here shows how you can have sometimes neck pain with pain shooting all the way down to the arm. And many times it can stop at the elbow, it can extend to the wrist, it can even go to the thumb. And when that happens, the reason you have pain going all the way down your arm is when you look at the spine, all the nerves that control the sensation in your arm come from your spine. And so your ability to feel your shoulders, your ability to feel your elbow, your ability to feel your fingers, all of those nerves that are responsible for that sensation come from your neck or come from your cervical spine. And when these nerves supply the sensation to the fingers, each one has a different number in the neck. And if they're getting compressed, you might feel that you have finger pain or wrist pain or pain going down to your elbow. It's not because there's a real issue with your elbow sometimes or your wrist or your fingers. It's because the nerve that supplies the sensation there is getting compressed and angry, And when it gets compressed and it's angry, it gets inflamed, and as a result, you start having numbness, tingling, you can even have weakness. And so that's all a result of disc herniations, arthritis, and very often a combination of the spurs from the arthritis as well as the discs will cause pressure on that nerve, which in turn causes the numbness or the pain shooting down your hand or even the weakness. The good news is that even if you have this, it doesn't mean you need surgery. So a lot of times patients, will delay coming to a spine surgeon or seeing a doctor because they're worried about something is going on with my neck. I don't want to see a surgeon because I'll need surgery, and I don't want to do that right now. And the good news is that in this condition, cervical radiculopathy, over 70 to 75% of patients don't end up needing surgery and get better with non-operative treatment or treatment without surgery. So that means out of every 4 patients, 3 of them will not need surgery and will get better without surgery. And so it's always better to have this evaluated to see what's going on, because there are many, many things we can do to make this better even before we talk about surgery. So we can treat this in many ways without even having to go to the OR. And so we talked about, what you feel when you have cervical radiculopathy or a pinched nerve. You can have neck pain. A lot of times it can be on one side. Sometimes it can be on both sides. You can even have weakness, but this kind of distribution here in the red, where the pain starts in the neck, goes down the shoulders, sometimes it stops at the elbow, sometimes it stops at the wrist, that is all considered completely in line with cervical radiculopathy. Trying to move on to the next slide here. All right. So as we said, the treatment is successful in over 75% of patients without doing any kind of surgery. A lot of times we can start you off on medications, physical therapy, a home exercise program. And if the treatment doesn't get better with that, then we can jump to doing epidural steroid injections. And the epidural steroid injections are actually very helpful for this because they contain 2 things, and each one of them does something different. And so when you go to a pain management physician or a physiatrist, when you get sent there by your spine surgeon, they will include a numbing medication in that injection that helps give you some immediate relief or short-term relief. And they also include a steroid, and the steroid is important because it helps calm down the inflammation over a matter of weeks to months. And so let's change gears a little bit and then talk about cervical degenerative disc disease. And when you Google this condition, the long story short here is basically degenerative disc disease is the medical term for arthritis. And so cervical degenerative disc disease means neck arthritis. So when you look at neck arthritis, this is different than hip or knee arthritis or shoulder arthritis, because unlike your hips or your knees, when you have arthritis in your neck, not only do you develop pain as a result of the arthritis, but you also start developing pressure sometimes on the nerves that exit the spine on the left and the right side. So if you look at this picture here, on every single level in the spine, there are nerves that come out on each side, one on the left and one on the right. And when you develop arthritis, the discs or this blue area in between the bones starts to collapse. You start developing spurs, which are shown here in the red. And as the disc collapses and the spurs form, you start having pressure on the nerves. And that pressure causes pain going down your arm. And if it's in your lower back, it can go down your legs. But that's why arthritis in the spine is a little different than arthritis in your knees or your hips, because it can cause severe compression on those nerves, and that can cause pain going down your arms. Many times when you get x-rays on patients, you can start these changes, you can start seeing these changes occurring as early as 40 to 50 years old. If you get x-rays on everyone above 65, over 80 to 85% of people will have changes. But just because you have neck arthritis doesn't mean you necessarily have symptoms from it. And so if you have neck arthritis, but you don't have any symptoms, neck pain, arm pain, you don't need necessarily any treatment for it. And the things you can do to help yourself to avoid this is, number one, smoking. Smoking has been shown to have a high association with neck arthritis. There are some occupational related things, like if you're doing a lot of heavy lifting every day, If you're doing professional sports, like professional athletes can develop it, especially football players who do spear tackling, and then also excessive driving. So we talked about why it matters, because arthritis in the neck can cause the radiculopathy, or the pinched nerve shooting down the pain shooting down your hand. It can also cause the myelopathy that we talked about earlier, which is where you get pressure on the spine itself, affecting your ability to walk and other things. And it also causes neck pain, or discogenic neck pain, which is pain from the discs in your neck. So this X-ray is kind of an example of what you might see in a doctor's office. And when you're looking at these X-rays, this is your mouth here. This is the top, or your skull. This is the bottom, and that's the back. This is the back of your neck here. And these are the bones in your spine. And if you see this here, these are the spurs that happen as a result of the arthritis. And you can see some disc space narrowing here. So where the nerves come out, you start having pressure on the nerves, which can cause the arm pain. So now that we've covered a lot of the common conditions in the neck, we are going to change gears a little bit and talk about the lower back. And I would say the lower back is actually quite more common than the neck for many older patients, but some people can actually have a combination of the two. And lower back pain is one of the most common conditions that patients are seen in clinic for throughout the United States. And so if we look here at lower back pain, we'll start off with spinal stenosis in the back. And so if you remember when we talked about cervical myelopathy, or pressure on your spine and your neck, a similar condition is also present in your lower back. Just like you can have pressure on your spine and your neck, you can also have pressure on your spine, or your thecal sac, in your lower back. And the reason that matters is because if that spine gets to a certain amount of stenosis or pressure, then some patients can develop difficulty with walking. You start having difficulty, walking like you used to. Some patients say, hey, I used to be able to walk a few miles. Now I'm only able to walk a few hundred steps, or barely down the grocery aisle in the supermarket, and I have to sit down and, take a break, or I have to lean forward on my shopping cart to feel any relief. That can all be a result of spinal stenosis. In fact, if you open a spine textbook, you'll see something called a shopping cart sign, which is a lot of patients who have arthritis in their lower back and who have pressure on the spine that's causing issues with walking. They have to lean forward on a shopping cart or bend forward to be able to relieve some of that pressure on the spine. And so that's one of the most common examples, or things that you can recognize as to whether you have any pressure on the lower back in terms of your spine. And just like the other conditions we talked about, just because you have this doesn't mean you need surgery. Whenever a patient first presents with this issue, or if you come into clinic for the first time, you will never ever be offered surgery to start off. You'll have to have conservative, non-operative treatment, because a lot of people can get better without surgery. And so again, going back to the point of, I see a lot of patients in my clinic who have avoided seeing a doctor or avoided seeing a surgeon for a very long time because they're worried about going in, finding out what's wrong, and saying, I don't want to have surgery now. And it is almost impossible to be offered surgery the first time you're ever evaluated for this, unless certain criteria are met, because non-operative or conservative treatment is something that is very, very successful in a lot of patients. And so what does that non-operative treatment include? One of the most common things we do for patients is we start them off on physical therapy. There are many lifestyle changes that you can do to help with this pain. You can do a lot of activity modifications, change the way you do certain things. And aside from physical therapy and medications and lifestyle changes, if that fails, we can still do epidural steroid injections. And that's similar to what we talked about in the neck for cervical radiculopathy, except that these injections are done in the lower back. And so now that we're talking about spinal stenosis, what are some of the symptoms that you can have if you have this pressure on your spine in your lower back? Some of the symptoms you can have include back pain and pain going to your buttock. You can have leg pain. It can be pain, it can be numbness, it can be tingling. Some people describe, sharp stabbing pain sometimes, and that's more with a lumbar radiculopathy or a pinched nerve. You can also have difficulty with walking, which is what this term here refers to, neurogenic claudication. You can start developing weakness over time, where your legs feel weak or they give out on you. And in very, very, late phases, you can have problems with peeing or, difficulty controlling that, but that's very uncommon. And so changing gears from stenosis or pressure on your spine and your lower back, we're going to talk about lumbar radiculopathy. And so similar to this term here that we talked about earlier, the cervical radiculopathy, lumbar radiculopathy is a pinched nerve in your lower back. And so what exactly is a pinched nerve in the lower back? I mean, how does that even happen? A lot of patients, don't understand why. If a lot of patients will have knee pain or ankle pain or hip pain, and they'll see other specialists and they end up in the spine surgeon's office and they say, I don't really quite understand why I'm seeing you because the pain is in my leg. So why am I here to see a spine specialist? Similar to the neck, the nerves that control all the sensation in your legs all come from your lower back. And so those nerves essentially leave your brain, they travel through your neck, travel through your mid-back, get to your lower back, and once they get to your lower back, they exit through small holes on the left and the right side of your spine and travel down your legs, giving you the sensation. And so when you develop pain shooting down your leg or numbness or tingling, sometimes it's because the nerve that supplies that sensation from your spine is getting compressed. And some people will think, there's definitely something going on with my knee. There's definitely something going on with my thigh. Although you may have knee arthritis or other conditions, a lot of times you have a pinched nerve in your back causing the pain going down your leg. And so many times you'll get physical therapy. If you don't improve, we can get an MRI to see where the issue is happening. And similar to the other conditions, just because you have this does not mean you need surgery. In fact, the vast majority of people who come with this do not end up getting surgery because they get better without surgery. So there are medications that we can give that can help with this pain from the nerves. And these medications can help quiet down that pain and make it significantly better. We can do lifestyle changes, activity modification. Physical therapy has been shown to provide a significant improvement in symptoms that is sustained and long-term. And if that fails, we can also do certain types of injections. There are different types of an epidural steroid injections. So your surgeon or your doctor will decide which one is best for you based on what the MRI shows and what your clinical symptoms are. But the vast majority of patients do not get surgery, and nor should you get surgery when you first come in with this problem, because we treat most patients conservatively. And if conservative treatment fails, then we sequentially increase the treatment for the next invasive level, and then the next invasive level. Surgery is only our last resort. You should never be getting surgery right off the bat unless there are certain red flag symptoms. So we talked about non-operative treatment, including medications, and then surgery being the last option. So what have some studies shown? Say you have a pinched nerve from a disc herniation and you end up needing surgery. What exactly does surgery do for a pinched nerve as a result of a disc herniation? So a lot of studies have actually been done, high quality long-term studies, and they've looked at what a microdiscectomy, which is one of the most common things we do for patients who have a pinched nerve from a disc herniation, and it showed that you have a significant improvement in both pain and function that gets better with surgery if you need it. And what function means is the ability to walk, being able to do your job, being able to do the hobbies that you have. And those studies have shown sustained relief that goes out to even 2 years. And so let's move on to the last most common condition in the lower back, which is lower back arthritis. So just like we have cervical degenerative disc disease or neck arthritis, we also have lumbar degenerative disc disease or lower back arthritis. The reason we're talking about this last is because the arthritis in your lower back can cause these two conditions here on the top. Arthritis in the lower back can cause pressure or stenosis on your spine, and it can also cause a pinched nerve. So although this condition is listed as the third one, it can cause these two other conditions that we just spoke about. And so kind of what we touched on before, lower back pain actually affects 50 to 80% of the population throughout their lifetime. So 5 to 8 out of every 10 people in this country will end up having lower back pain. And we spend close to $100 billion on this condition throughout the United States. In fact, the only thing that's more commonly seen in doctors' offices besides lower back pain are respiratory infections or upper respiratory issues, like the flu or the cold or those kind of conditions. What are some risk factors for back pain? What can put you at risk for back pain? Obesity, being overweight. The reason obesity causes issues with back pain is because when you carry all that weight, all that force is transmitted through your spine and can cause some pain, can cause some accelerated wear and tear. And so weight loss is actually one of the most effective ways to improve your back pain. A lot of times, if you lose 10% of your weight, that can cause a significant improvement in your back pain. Another common reason, another common association where studies have found that a lot of patients who have back pain also smoke. Vibration or lifting, those are occupational related things. If you sit on a desk for a long time, if you sit on a couch for a long time for hours and hours and hours without standing, and that occurs throughout your lifetime for years and decades, that can increase your risk for back pain. And interestingly, also being unsatisfied with your job can also increase that, but that's a different discussion. So there are different types of back pain. Back pain can be as a result of the muscles around your spine. That's called musculogenic. And musculogenic back pain occurs because you have muscles on the left and the right side of your spine that are responsible for holding your spine upright. And when those muscles get aggravated or inflamed, that can cause back pain. You can get it from the discs in your lower back. So over time with arthritis, these discs collapse and they cause pain. It can be mechanical pain, but one of the other common causes is also SI joint pain or sacroiliac pain. A lot of patients know other people who've had sacroiliac pain, and that's also something that is treated extensively with conservative or non-operative treatment. So now that we've talked about all the common conditions, we can start to talk about what is minimally invasive spine surgery. I'm a specialist in minimally invasive spine surgery. Not all patients are candidates for minimally invasive spine surgery because there has to be a constellation of a clinical history, imaging findings, and goals of treatment that actually make you a candidate for minimally invasive spine surgery. One of the most common things or abbreviations you'll hear for minimally invasive spine surgery is MIS, and it's basically the first letter of each of those words. So MIS for minimally invasive spine surgery is actually becoming quite common because it actually has quite a few benefits, and we'll go over some examples, and it'll make a lot more sense now that we understand these conditions in the lower back. So these are just some examples from a surgeon standpoint and from a patient standpoint for what minimally invasive spine surgery is. So if you look at this top row here, this is an example of a minimally invasive spine surgery where we can do either a fusion or a discectomy through a small tube. And if you look at it, this is the incision from a discectomy where we take out a disc that's pushing on the nerve. And this is a dime or nickel here. You can see how small that incision is because the tube, that is just the size of the tube. And so you can imagine with a much smaller incision, you have less post-operative pain, a faster recovery. Aesthetically, it looks a lot nicer. So a lot of patients opt for minimally invasive spine surgery if they're candidates for it. On the lower row here, you can see an open or a traditional surgery. And this is the way that surgery has traditionally been done for decades, where you make an open incision, the surgeon visualizes the spine. And after you visualize the spine through a common traditional opening, you do the surgery and then you close it, and you end up with a larger incision. And both approaches are completely acceptable. Both approaches are achieving the goal of surgery and allow you to get better because they resolve the conditions that you have. But the difference is how big the incision is, the level of post-operative pain, and the speed of the recovery. So the advantages of minimally invasive spine surgery, you basically have less soft tissue damage. What that means is we're not messing around with a lot of the muscles or the soft tissues that we would be doing with an open approach. There's less blood loss during surgery because the incision is smaller. We're not changing much soft tissue like we would do or manipulate the soft tissue like you would in an open surgery, so the blood loss is less. And for certain types of surgeries like fusions, they've been shown to have a shorter hospital stay. So you may stay, a day or two less than a traditional fusion. And you also can have a lower risk of infection depending on the type of the procedure. And so, when you look at the main advantages, less pain, less blood loss, less soft tissue damage, sometimes a shorter hospital stay and a lower infection rate. But this varies depending on what type of surgery you're getting. So let's talk about the tubular discectomy. This is one of the most common minimally invasive spine surgeries that I do. And we talked about lumbar radiculopathy being a pinched nerve. And we can see here that, sorry, give me one moment. All right, and so when we look here, when you're looking at a tubular microdiscectomy, you can see here that we're taking off a disc herniation. And this is the portal that I actually work through. It's a small tube. You can see it on the x-ray here. And instead of making it a open incision, we may use a small tube that allows me to get down to the spine. We get down to the exact area where your disc is pushing on the nerve. We remove that disc and we close it up. So how does this actually look in real life? This is the surgery when you're looking at a patient from cross section and from the side. And so when you're looking here, this is kind of almost like a bird looking down the spine. This is the front here, this is the back, and this is the side. These are the muscles in your back. You can see this tube going immediately down to where you need to be to take this disc off. If you're looking at it from the side, so this would be the top here, this would be the bottom, and that would be the back. The tube goes down immediately to the area that's problematic. We use a very small instrument to get down, take this disc off that's pushing on the nerve, and then we close it up. And the example of that tubular microdiscectomy is this image right here. This is an example of a tubular discectomy. This small incision here that's about less than the size of a dime is exactly what we're doing in a tubular discectomy rather than an open incision such as this one. So aside from a disc herniation, we can also now do fusions, or if you need a fusion, we can do screws and rods through a minimally invasive approach. And so there are two main types of fusions that we can do in a minimally invasive fashion. And this is only if you need a fusion. Compared to a traditional procedure, this is an open fusion, the traditional way that's been done for decades. If this is the cross section, or if you're looking down the spine, this is the bone in your spine, this is the front, this is the back, and these are the sides. This little area is the bump that you can feel on the back of your spine. And so if you're doing a traditional surgery, we open up this entire area, we expose everything, we move all the muscles out of the way, and we do a fusion. In a minimally invasive, you can do a tubular fusion, you can do a mass TLIF, but essentially the area that we work with is a lot smaller and allows us to access the area for the fusion in a much smaller incision. And so this is an example of a different type of fusion called an XLIF. And you can see the size of the incision. It's done through a incision the size of a paperclip. An XLIF is an incision that's also minimally invasive that can be done from the side of a patient. So when we look at these fusions, you look through these areas that we work through as surgeons. The area that we do the surgery through is much smaller. So we manipulate a lot less of the soft tissue in your spine. And as a result, your stay in the hospital is shorter. Now this varies from patient to patient, but your rehab is much faster, the post-op pain is better, and so on. And those are all the benefits. And these are little examples of incisions for minimally invasive versus open. If you do a minimally invasive surgery, you have a big incision on your lower back where we do the exposure the traditional way, versus an MIS or a minimally invasive procedure where we make little tiny nicks in the skin and able to access your spine through these little openings, which allows us to make an incision this size rather than the bigger traditional incisions. And that's what's meant by minimally invasive spine surgery. There are many different techniques. As I said, we can do these through tubes, we can do this through small openings, but the end goal is the same, which is smaller incision, give you a better chance at less post-operative pain, a faster recovery, and so on. That's what I've got for today. I appreciate you tuning in, and we can take some questions.
All right, thank you very much, Dr. Minkara. Fascinating. Just real quick, what got you interested in doing spinal surgeries? Just this is my curiosity.
So when I was a medical student, I worked with a surgeon who was very well known in the spine community, and I was able to, observe him in the OR and in surgery. And I even got to see some patients after their surgeries, and I was, quite amazed by how well patients did after surgery and how much function they recovered after surgery. A lot of times you see people who have been living with leg pain or people who have not been able to walk for a very long time, and you do the surgery, you have them do the physical therapy, and they go to having much more function, doing much better. And it's just absolutely incredible how much function you get back when you're able to do this. And the shocking thing is a lot of people, before they end up being referred by their primary care physician or someone from their provider team to the spine surgeon, they think that this is just how I'm going to live. I've become 70 or 65, 70, 75 years old, and this is just a normal part of aging, when it isn't. And the thing that sticks with me to this day is, I still remember the patient. I remember her name and her face, and I was able to see her before surgery. I was able to watch the surgery happen and then see her after surgery. And this was a patient who had slowly kind of diminished in terms of her function. She had gone from being someone who likes to play tennis, slowly deteriorating to using cane, and then over several years she went to using a walker. And after a long period of time, I think it was about 8 to 9 years, she ended up essentially using a wheelchair.
Wow.
And she ended up getting a decompression of her spine, where we take the pressure off of the spinal cord or the thecal sac, and she got a fusion because she had instability in her spine. And several months later, after doing the physical therapy, after doing the home exercise program, her function had significantly gotten better. And I saw her walk into clinic, with the use of a cane, and you see someone reverse their lifestyle and get so much better. And being able to give patients that ability is one of the most satisfying parts of my job, because my goal when I see a patient is, how can I make their quality of life better in the most conservative way? So some people can, get improvement with injections and physical therapy, and even if they end up needing surgery, it can cause a significant improvement in the way you live your life. So that's really what drew me to it, and that's also the reason I've done extensive research in spine. I've published a lot of studies just to allow us to understand how to make patients better and how we can optimize people to do the best after treatment.
Awesome, thank you. Thank you for your service. It really, you're making a difference in a lot of lives. By the way, Dr. Minkara literally came from surgery, and he was able to get on this call at 6:58, literally after leaving the operating room. So thank you, Dr. Minkara, for taking care of people right up until this program.
I appreciate that.
So we've got a lot of questions, and I'm going to try to do the ones that are more general, and ones that you didn't already address. So let's see. What is the success rate for minimally invasive surgery versus open surgery for the same type of surgery? For example, like a cervical fusion.
Yeah, so that's actually it's a very good question. The answer is variable. The reason I say variable is because, number one, it depends on what condition you have and what surgery you're getting. Now, a lot of variability also is involved in terms of what procedure you're getting. So when we spoke about the fusions in the lower back, there are different types of fusion, like XLIFs, where you go from the side of the spine, or you're on the side, basically on the left or the right side. And there are T-lifts where you go from the back through a smaller opening. But depending on who your surgeon is and depending on what procedure you're getting, the success rates of minimally invasive surgery can be quite close to traditional open surgery. Now, the techniques that have become available in the last 10 or 15 years have significantly improved the success rates of minimally invasive spine surgery. And so if you were asked this question, 2 decades ago or 15 years ago, the success rate was lower for minimally invasive. But now with the new technology that we have and the new implants that we have, that has significantly increased the success rates of these. And so one example I'll give is if you are doing a minimally invasive spine surgery, your accuracy can actually be down to 1 or 2 millimeters because we can do this through computer navigated surgery, where we essentially use computer navigation, and it tells me as a surgeon exactly where I am and where I'm putting your implant and where I'm shaving off some of the bone, where I'm shaving off some of the arthritis. It tells me exactly where I'm doing your surgery, and that gives me an extremely high level of precision, which wasn't available, many years ago. And so with these new implants and combined with the new technology, it gives us a high level of precision to make sure that we are doing the surgery correctly. But if you are doing minimally invasive spine surgery, the surgeon that will be willing to do that is a surgeon who does MIS surgery, because surgeons can do open or traditional surgeries. They can do minimally invasive. And even as a surgeon myself, I will do a minimally invasive surgery on patients who are candidates, and not everyone is a candidate. If I feel that a minimally invasive surgery decreases your chances of a successful outcome, then I would recommend the open procedure.
Great, thank you. Very, very helpful answer. Can you help someone who has had multiple fusions in the past?
Yeah, so revision surgeries are one of the most common things that I do. I see a lot of patients who have developed issues after having a prior spine surgery. A lot of times you can have wear and tear or adjacent segment disease above or below your prior fusion. And I would say that actually is a very large part of my practice. And I see patients in every clinic or almost every clinic who have had developed either conditions as a result of prior fusion, or a lack of a fusion where you have something called a pseudoarthrosis where the fusion doesn't take, or hardware that has failed from a prior surgery, and revisions are something that I specialize in as well. And so if patients need to be seen for that, I'm more than happy to take care of that.
Great, thank you. So for example, if someone has numbness in their feet following surgery, this probably isn't common and is something that you might be able to help them get rid of after surgery?
It depends on what the cause of the numbness is. A lot of patients can have surgery, for example, a fusion done. They may develop some arthritis or develop disc collapse or pressure on the nerves above or below the fusion, and that can cause some pain or numbness or weakness. And that is one of the surgeries that I do. It's called a revision, where you can do a revision decompression or a revision fusion. And absolutely, there are many patients who can benefit from it, but it varies from patient depending on what the problem is. Last 2 weeks ago, I saw a patient who had a prior fusion who was fused from L4 to S1, and they had significant stenosis or pressure on their spine at the area above the fusion. And she also had numbness and tingling in her legs as a result of pressure on the nerves in that area. And she didn't need a revision fusion. All she needed was a revision decompression. So we took the pressure off of the spine, we decompressed the nerve roots, and a lot of patients can get quite a bit of relief from those surgeries.
Excellent, that's great news, very encouraging. All right, someone is 69 years old and they think that they will probably need a bone fusion. How does their age affect that? And is there an age limit after which bone fusion will be less effective?
So I think that there are different types of considerations when we look at patient and age. There is true age and there is physiologic age. There are a lot of people who are 60 who, from a physiologic standpoint, are much younger than their actual age. And there are some people who are actually, physiologically much older than their true age. Some people have osteoporosis. If you have osteoporosis and you need a fusion, that's a whole different story. Some people have excellent bone quality and they have minimal risk factors and they don't have any diabetes and they don't have any other comorbidities. All of that picture gives me an idea of whether or not someone would be a good surgical candidate. And so, the reason I say this is because surgery, especially spine surgery, it's not a one size fits all. When you come and get evaluated, we take into consideration your other medical issues. You know, if you have diabetes or if you have hypertension, if you have all these other medical conditions, we look at your bone quality, you know, whether you have osteopenia or osteoporosis, and we look at your risk for surgery. All of those get taken into consideration if you need a fusion. But for most patients, even if they do have osteoporosis, there are treatments that we can do before, you know, spinal fusions where we improve the bone quality to give you the chance of a successful outcome. And so, you know, even if someone comes to me and they have osteoporosis and they've failed conservative treatment and they've gotten injections and they've done physical therapy, you know, to give you the best chance of success, sometimes these patients with osteoporosis, most times, they end up getting treatment for their osteoporosis with infusions. You know, there are medications like Prolia or other things that can help improve them. And after that's treated, then we do the spine fusion because, you know, my goal as a surgeon is not to just do the surgery and, you know, wish you the best of luck. It's I am invested in making sure you have a good, positive, successful outcome. And so what that means is we optimize your other medical issues before we do the surgery to give you the best chance at that.
Awesome. Great. I mean, these are perfect answers, so thank you. All right. If a doctor recommends to someone to see a nerve specialist, would that be you?
A neurospecialist as in a neurologist?
They say a nerve specialist. That's the
Nerve
terminology that they used.
So that depends on the condition. Sometimes patients will come in with issues with walking or ambulation, and sometimes it may not necessarily be from the spine. You know, if we do a workup and there are other considerations, you know, I had a patient a few weeks ago come into my clinic and they had problems with walking. You know, we did a few MRIs, we even got a brain MRI, and you know, they unfortunately were diagnosed with multiple sclerosis. And so there are certain conditions where a spine specialist can potentially diagnose you with something, but as a spine surgeon, you know, after I diagnose that patient with multiple sclerosis, I don't treat multiple sclerosis.
Right.
And so in those conditions, I send them to a neurologist. You know, other conditions, for example, if it doesn't seem like your conditions are coming from a, you know, the spine, we can get EMGs. But there are a multitude of factors where if I don't think that your condition is necessarily coming from the spine, or if I think there may be another diagnosis, I can sometimes send a patient to the neurologist for, you know, a further evaluation to make sure we're not missing anything.
That's great. That's really helpful and a great answer to that question. Thank you. Okay, so someone says discectomy. How do you live without the disc cushion between the vertebrae? Or are you only removing the portion of the disc that is protruding? And
Yeah.
wouldn't this be repeatedly necessary as multiple levels with many arthritic spurs growing over time?
Yeah, so that's a very good question. When we do a discectomy, we do not remove the entire disc in between the bones because that's called a total discectomy, and all studies have shown that that is not a good idea. The only thing we are doing in a discectomy is we are taking off the disc that has herniated or pushed out, and when it herniates or pushed out, it's pressing on the nerve, and so we protect the nerve and we take out the disc only that is not where it's supposed to be. All the other disc remains in place, and that is the cushion in between the bones. Now, some people can have more than one levels of disc herniation, but that depends on whether they have a slip, like a spondylolisthesis associated with it. That becomes an entirely different situation. But when it comes to recurrence of the disc, you know, the highest risk factor, or the people that are most risk for getting a disc herniation, are people who have had prior disc herniations. And so if someone gets a discectomy and they have a repeat disc herniation, at that point we have a discussion as to whether they get a revision disc, or if it happens for the third time, some people can get a fusion because you can't just keep repeating the same discectomy over and over again. But sometimes a disc herniation can happen in combination with a slipped disc or like a spondylolisthesis, where one bone is toggling forward and backward compared to the other bone. And when you have that kind of instability, then sometimes you get a fusion from the onset, depending on what that is associated with. So to answer that question, if it's an isolated discectomy for a disc herniation, we only remove the disc where it's not supposed to be. But if it's a disc herniation in combination with another condition like a spondylolisthesis or a fracture that causes a isthmic spondylolisthesis, then that would usually require a fusion.
Great, thank you. Very helpful answer. All right, is it possible to treat scoliosis with MIS, and are less aggressive treatments helpful?
So, when it comes to scoliosis, one thing I will say is that a lot of patients have degenerative scoliosis, or scoliosis that happens as a result of arthritis. There has been a huge shift in the approach to degenerative scoliosis because there are certain conditions that have to be met for you to get surgery to correct that scoliosis. A lot of times, the scoliosis is just a red herring or a distractor, where the real issue is a disc herniation or one level of instability or one specific area that is causing the problem. And so I would say the vast majority of the times when someone comes into my office with scoliosis, it isn't necessarily the scoliosis that's causing the problem. It's a far smaller thing. And so, I have seen patients who came in and wanted to ask or are getting a second opinion for a surgery like a T10 to pelvis fusion. That is a huge surgery. It is a massive surgery done to correct scoliosis. And many times, their pain can be a result of a disc herniation from one level or a spondylolisthesis from one level. And the reason, that's not to say no one needs a scoliosis correction, but you have to be sure that you actually need this surgery because it is a very involved surgery with many complications, and only certain patients really, really need it. Now, if you do need it, there is a possibility to do MIS, but a lot of studies have shown a far higher success rate with a traditional approach for scoliosis correction. But if the issue is coming from only one level, or if you're having a disc herniation or a spondylolisthesis at one level, then yes, you could get a minimally invasive surgery to correct that. But I would caution patients on getting a large scoliosis deformity correction surgery unless they absolutely need it. Because if you get x-rays on 100 people walking on the street with 0 symptoms, some of them will have scoliosis as a result of arthritis, but none of them need that surgery because they don't have symptoms. Just because you have scoliosis does not mean you need surgery. It may be a far smaller issue that can be addressed.
Great, perfect answer, thank you. All right, and this is going to be our last question. And I'm sorry to all of you who had so many questions. You can reach Dr. Minkara through the information that's on your screen there. What is the average time of recovery for MIS, and what does the first few weeks look like after going home?
So the most pain is usually in the first several days after surgery. When we do the surgery, we inject a local numbing medication, and that numbing medication wears off after 48 hours or so, which causes an increase in pain level. But when it comes to a minimally invasive fusion, for example, a lot of patients will stay for only a day or two after surgery, compared to 3 or 4 days for a traditional surgery. And you get outpatient physical therapy. Now, a lot of patients who get a traditional fusion, many of them end up getting home healthcare or home physical therapy, where someone comes to their home and does the physical therapy for them at their home. But that is in comparison to a minimally invasive fusion, where I've seen a higher number of patients elect to get outpatient therapy because they don't have problems getting in and out of a car. They have less pain, which allows them to go to a physical therapy office. But this is a generalization. It depends on the minimally invasive technique. If you're getting a minimally invasive surgery for a disc herniation, that recovery is far shorter and faster than a recovery for a minimally invasive fusion, because removing a disc is far less invasive than putting in screws and rods, even if it's minimally invasive. But to answer that question, the recovery is you're usually in the hospital for a day or two after surgery. You go home, you can either get home physical therapy or outpatient therapy. There are certain restrictions you have to follow, like no heavy bending, lifting, or twisting after surgery to allow the fusion to occur, because although we put in the screws and the rods for a fusion, your body is the one that has to be able to successfully heal the fusion. But on average, and as supported by a lot of studies done by both neurosurgery and orthopedic spine surgery, the minimally invasive approach for many of these procedures, whether it's a fusion like a XLIF from the back or from the side, those have usually a faster recovery, less pain, and a better overall outcome in the short term in terms of your functional and pain level. However, it varies from patient to patient. And even if you want a minimally invasive surgery, some people are not candidates for it based on what's going on. So if someone needs a revision, sometimes they're not candidates for a minimally invasive surgery depending on the location of the issue.
Got it. Dr. Minkara, thank you so much. The information tonight was amazing, really helpful, really went in depth, but also kept it so that we could all understand what you're saying. And that's appreciated by all of us lay folk here. So thank you so much for your time. Thank you so much for putting this together. Again, you can reach Dr. Minkara we're going to get out of this soon. So take a picture of that screen so that you can have access to Dr. Minkara and head out to see him in either Barrington or McHenry. Have a great night.
How many more questions are on that were unanswered?
Oh, a lot. Too many.
All right. Well, thank you for hosting, Karen. I appreciate it. And thank you everyone for tuning in. We had quite the show today, several hundreds of patients. So thank you. I appreciate it.
Thank you all very much. Have a great night, Dr. Minkara, you and everyone else at home too.
Absolutely. Bye-bye.
Bye-bye.